So hello to everyone. I'm Paolo Ghia, and I'm working in Milano at Università Vita-Salute San Raffaele, where I am directing the CLL program, so the strategic program on chronic lymphocytic leukemia that is dedicated entirely to patients affected by CLL. And we are also doing basic research in mouse models and in vitro models that indeed allowed to translate many of the findings into clinical setting with novel drugs approved for this disease. So the CAPTIVATE study is a phase 2 international study where patients affected by chronic lymphocytic leukemia have been treated with first line with 3 cycles of ibrutinib alone to debulk the patient, and then followed by 12 cycles, 12 months of combination of ibrutinib plus venetoclax. At the end of the 12 months of combined treatment, patients were randomized based on the level of MRD that were achieved, and in particular, patients who were in undetectable MRD were randomized to either discontinue the treatment, so a placebo arm, or to continue treatment with ibrutinib. On the other side, patients who did not achieve unconfirmed undetectable MRD, they were randomized to continue treatment, either ibrutinib alone or ibrutinib plus venetoclax. The data that we presented at ASH is indeed the 2-year disease-free survival analysis, which follows by 1 year the primary analysis that we already showed of 1-year disease-free survival. Disease-free survival is a little bit more complicated than PFS, progression-free survival, because it also considers the lack of MRD relapse beside the progression of disease and beside death. And having said all this, the interesting point is that with 1 additional year of follow-up, no additional patients have progressed or had MRD relapse or have died. So that makes that patient who achieved undetectable MRD and were randomized to placebo or ibrutinib, these patients have now still more than 95% disease-free survival after 2 years of follow-up. And there is no significant difference between the 2 arms. When we look at the patient who did not achieve undetectable MRD and they were randomized to ibrutinib or ibrutinib plus venetoclax, also this patient had a long-term benefit with a 3-year disease-free survival, which was more than 95%. And altogether, all patients enrolled in this study indeed had a progression-free survival, which was more than 95% after 3 years of follow-up, really indicating that by selecting the appropriate treatment based on the level of response, one may really tailor the treatment and have a equal benefit for all patients. Now, interestingly, we obtained this efficacy without an increase in toxicity. The only increase has been seen in diarrhea, in the rate of diarrhea, which was indeed present in more than 50% of the patients, but in the vast majority, if not all patients, was of mild degree, grade 1 or 2. For the rest, all the adverse events that we observed were compatible with the use of single drugs, and therefore we had a low rate of atrial fibrillation or low rate of hypertension. On the other side, we had neutropenia affecting between 30 to 50% of the patient, particularly associated with venetoclax. But interestingly, this did not associate to an increase in infections that were present only in 8% of the patients.